Good afternoon, and welcome to How HIEs Are Making the Patient Information Anywhere Dream a Reality Today, a webinar tweet chat combo from HealthSystemCIO.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. As you think of your questions, you can go ahead and send them into us using that Q&A box in the lower right-hand corner of your screen, and leave the default set to all panelists. We'll be posing those later in the program. And you could download the deck by using the URL on your screen. It's at the bottom of some of our slides, and it also will be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to hear from our good friend Chuck Christian, VP of Technology and Engagement with the Indiana Health Information Exchange. Then we're going to hear from Douglas Dietzman, Executive Director of the Great Lakes Health Connect, HIE. And then we'll hear from David Kendrick, CEO of MyHealthAccess, HIE. So without further delay, we're going to turn it over to Chuck Christian. Chuck, thanks so much for joining us today.
Well, great. Thanks, Anthony. I appreciate the opportunity to speak on a topic that's gotten more and more dear to my heart than I ever thought when I was working in southern Indiana. Thanks, everybody, for joining us today. I'm going to tell you a little bit about HIE. As Anthony mentioned, I'm the Vice President of Technology and Engagement for the Indiana Health Information Exchange, a company that I was a customer of for several years when I was the CIO of Good Samaritan Hospital down in Vincennes, Indiana. But I get the privilege now of working with folks like David and Doug on some of the very important work of this thing called interoperability that we're trying to move forward in the country. So HIE was only formed about 3 years ago. It's basically a trade association for the very successful HIEs in the country. We cover a grand majority of the United States of America, and we have members in 35 states, 55 members, and we're all providing a person-centric health record. And we're basically customers not only to our providers, but also the patient populations which we cover. And the HIE members today are providing patient records and interoperability services that cover about 195 million patients, which is well over 50% of the population of the United States. Like I mentioned, we're only about 2.5, 3 years old, and we're growing very, very rapidly. So what we try to do is be an unbiased community data trustee of health information for the single community, and so we can bridge and connect healthcare. And so one of our panelists, Dr. Kendrick, I was going to call you Dr. Dietzman, but actually David Kendrick came up with the idea a couple of years ago of this concept called the patient-centered data home. And that's what we're going to talk a little bit about today. This is an extremely simple concept, and the important part about it is that we believe that a patient needs to have their record available wherever they're getting care. We do a lot of traveling in the country, and our records need to follow us. We recently had a tragedy in Las Vegas. A lot of people from all over the country out there, and unfortunately, people needed emergency services, and would have been great if we would have been able to make their patient's record available to them. And David and Doug are going to talk a little bit about how HIEs have participated in those, not this kind of disaster, but the other disasters like Katrina and others. And so what the patient-centered data home is a concept in order that allows us to move the patient's record wherever they need it at that point in time. So a couple of three key questions that the providers want to know is, one, where are my patients getting care? And where is that information that I can get, that I can query and get more information about my patients? And the other thing is, where's that patient getting care right now? What do I don't know? What do the people giving care to my patients don't know about that patient? And the other thing is, how do we make sure that we identify the patients appropriately? And that's one of the things that we're working out and solving with this issue of patient-centered data home. And how it actually works is very, very simple, and this is why I like the concept a lot, is that if you look at the screen, you have a patient gets admitted to a hospital or a healthcare provider on the left-hand side of the screen. And that ADT alert or that ADT transaction goes to what we refer to as a non-home HIE. And I'll use the example of this little bitty event that we have in May in Indianapolis called the Indianapolis 500. About 400,000 of my closest friends show up in Indianapolis, and inadvertently people are going to need some level of care. So we get that registration, and what our exchange does will look at the transaction and says, does this patient's zip code in Indianapolis, in the areas that we serve, or somewhere else? And so if we find that the zip code is somewhere else, we have a lookup table, and we'll figure out that the patient is from actually Oklahoma, which is David's exchange. And so we will send an alert to that home HIE, which is in Oklahoma, and ask them, do you know this patient, and do you have any records on this patient? And they say, they can say, yes, we do, or no, we don't. And if they do, then we can request additional records on that patient that can be made available to the people that are providing care. Now, at the end of the visit, when the patient goes home, back to their home HIE, the non-home HIE can, because we know where they're from, and we now have that patient identifier from their home HIE, we can bundle up a CCDA or other clinical record and forward that back to their home HIE so they can have benefit of that summary of care that happened outside their market. And their physicians also know, because of the ADT alert that sent to their home HIE, that the patient actually was admitted somewhere else. And so they get that advantage of knowing where that patient was admitted, so they don't have to wait till the patient shows up in their office for that visit. And one of the things we've done on the screen now, you can see the projects that we've had going for quite some time. We actually have three projects, all in blue, about HIEs that are actually communicating today with each other. We have the one in the Midwest, we have the one in Oklahoma and Arkansas, and then we have the one out west, and those are expanding. Currently, we have 17 HIEs exchanging data among themselves, and those will soon expand to another 19 that are also expanding that are in green. And the one thing that we started working on so far this year is having these regions start communicating with each other. And so if a patient shows up in Indianapolis that's from Nevada, through this mechanism, we'll be able to receive that data on that patient and vice versa. So it's a really interesting thing. It's a very, very simple concept that doesn't require a lot of overhead or expense in order to move this data from one side of the country to the other. And I think that David's going to show you some additional data points as well. So at the end of the day, what you really should know about HIEs, and one of the things I was thinking about my fellow CIOs that may be on the phone, is why does this really make a difference, for you? Well, the one thing that I think that everybody is starting to understand is all HIEs are not the same. Some of the services are similar, but there's not actually any of them that cannot participate in the patient-centered data home, regardless of what their regions are, what their structures are, or what their technology stacks are. These are all the transactions are based upon industry standard transactions that any HIE in the country can participate in. And so this is one of the reasons that we felt that this is a very simple platform that everybody can participate in, that can cover a large swath of the country inexpensively and very, very quickly. We've stood up the services within these regional demonstration projects that are now in production very quickly. And we can very quickly cover other larger sections of the country. So that's kind of the PatientCentered Data Home in a nutshell. I'm going to hand it back to Laura. Not Laura, I'm sorry. Laura just texted me. Hand it back to Anthony. Anthony, I'm going to hand it back to you and let you introduce Doug and move forward with that. Thanks very much.
No worries, my friend. Thank you very much. Now we're going to hear from Doug Dietzman, who's the Executive Director of the Great Lakes Health Connect HIE. Doug, thank you for joining us today.
Thanks, Anthony, and really appreciate the opportunities to participate on this panel as well. Anytime I get to be with my friends and peers, Chuck and David, that's a good day for me. So I'm pleased to be able to share a little bit about what we're doing. I've been, for those who don't know, involved with Great Lakes for the last 8 years since its inception, kind of trying to stay ahead of the industry and everything that's going on. It's been a lot of fun, and with my background having worked in some health plans and health systems and providers, it's always struck me over the years that there was a way for everybody to work together in a way that would be collaborative but not give away the golden jewels that each prized and used so heavily, and I think HIE is the perfect place where that comes together. Great Lakes itself is really the HIE company in Michigan, and a company nonprofit founded specifically and exclusively to do health information exchange activities between stakeholders, vendors, physical, behavioral, and social. And you see there some of our spread, 129 hospitals, 4,000 connected participants in some way. So in the lower peninsula of Michigan, we have a lot of focus. And I think on the topic, it's not a pipe dream anymore where a person living in Detroit who goes up to Traverse City and runs their snowmobile into a tree ends up at Munson, that the data that's been contributed in the Detroit area for them is immediately available to the folks at Munson to know how to treat that person. And then as well, when they go back to Detroit after being treated with no phone calls or faxes, the information from Munson is immediately available for the providers here in Detroit to know what happened. So data is flowing and is being made available today in some pretty great ways. Let's see. There we go. One point I want to make, and I think it's unique to HIEs, there are lots of ways that data can be queried or exchanged or shared. And the question, I think, is often, well, what is the value proposition for HIEs specifically? And I think it boils down to, this is a fairly common picture we see, but I think what's important is that HIEs encompass the physical space, the behavioral space, increasingly the social services, integrating with payers and the care management activities going on there, as well as risk is delegated to ACOs and other provider organizations and connectivity with the state. So when we talk about a patient story, it isn't just what any one EMR might have as we discretely query between each other. The story flows across all three of those elements, and each one of these organizations around the circle has their own mission, their own strategy, their own purpose for being. And so I think what it's incumbent upon us and what we've tried to do is go into each one of those and say, we need to treat you as an individual organization and help you be successful. But as we do that with each one of the organizations and stakeholder groups around the outside, as we help and do things in a common platform, we kind of raise the whole collective. So kind of termed that phrase collective individualism, where HIEs are involved in all of those spaces, helping to meet the specific needs of their participants while at the same time providing this broader benefit and community value. And the example that I'll talk through today is, most folks have heard, I think, about Flint and the water situation, crisis that occurred there and continues to be felt in that community. Great Lakes had been working in Flint for a number of years to try and integrate that healthcare ecosystem together. Good partnership with the Greater Flint Health Coalition and the good work happening there, bringing stakeholders together. But a lot of times it's why. and we're really busy in our system, our hospital, provider group, got a lot of things going on. Why do I need to care about health information exchange? And I think the water crisis presented another reason why. Chuck mentioned Las Vegas. We've seen things in Houston and Florida and Puerto Rico, and these situations keep coming up in different ways, but it was a reason why that the community needed to connect because no one organization could fix or address this problem on its own. And while there was a lot of resources being brought to bear in the region for water, and people were bringing in filters and making sure that was done. There were lots of plans to replace and try and remediate the pipes and the water infrastructure that was actually delivering the water to the community, figure out what to do there. There's even some work to figure out, okay, what do we need to do as kind of individual health systems? But as Great Lakes looked at the situation, we said there's an infrastructure need that's not really being addressed or really even understood as being needed, and that is, as we have some number of thousands of kids and many more adults that are affected by this, how do we ensure that as they move around from the school nurse to their pediatrician to cognitive development sorts of folks who are doing assessments on the effects of lead over a long period of time, how does all of that get pulled together in an integrated way so that we actually properly take care of the folks in the community rather than assessing them 15 times and having all the providers doing things in kind of a disjointed way? And so we brought a set of tools to the table. There's the longitudinal health record that gives a view to that story across providers in an integrated way. How do we refer and coordinate the transitions that are going to be required as these individuals that are affected need to be moved from one care setting to another to make sure that they're getting what it is they need? Clinical messaging is important in that. Ongoing active health monitoring. You see all of the different settings that needed to be part of this structure that no one EMR can handle on its own, no one health system can handle on its own. In this particular community, there were continue to be three EMR systems at the three hospitals. So there's an Epic, a Cerner, and a McKesson. And with as good as they are, no one could handle it. And then you get into the plethora of other systems across the other settings. So Great Lakes at the time, and we're in the middle of this investment, said, you know what, we need to demonstrate the importance of this, and we need to put our money where our mouth is. So our board actually approved $250,000 of our own reserve monies to donate to the community to eliminate some of the hurdles that get in the way of developing this sort of infrastructure. Cost, vendor cost. Folks might want interfaces, but they can't afford the vendor. So we said, well, we won't charge you. In addition to that, we'll take care of the vendor cost to get you connected in. We'll put somebody on the ground there who lives in that community who will specifically help this region get connected and see the various aspects of the commitment there. But felt very strongly that with all of the other investment and infrastructure, that this was a core infrastructure that we had to have in order to effectively care for the residents in the community that we're serving there. And kind of lastly, as I wrap this up and applying it to the patient-centered data home, what's interesting is there were kids in the community affected who live there. There were kids affected in the community who just went to school there but didn't actually live in the affected areas, but then were part of the affected population. There were kids who were affected because they came and spent time with one of their parents who lived in the area and lived part-time with another parent in another part of the state, came in visiting with grandparents. So pretty quickly it was understood that this was not just a little community regionalized problem, and residents and the families continue over time, as you'd expect, to move into other areas within the state and outside the state. So the question really for us as an HIE is how do we improve that awareness, both to as people are seen outside the state, by clinicians? How do we get that information back so that we round that history out? And then as people are moving or going into other areas, how do we make that information related to this particular problem on the problem list, or however it's documented, how do we make that available to the other clinicians so when they move there's a seamless transition and availability of that data to continue to treat them the way they need to be treated over the long haul. And I think this gets to that collective individualism topic I talked about before. Each one of us are working really hard in our communities to link that physical, behavioral, social, create that story of the patient and integrate it into workflow at a very local level. So on an individual basis, we're out working hard to do that. But we benefit greatly when we can connect those individual components that we're working on to each other to lift the whole kind of national fabric up. And that's what Patient-Centered Data Home allows us to do, and we're actually doing, as Chuck mentioned, kind of in real life today, and starting to share that data amongst ourselves so that individually we're solving our mission and working hard at doing it, but collectively we're expanding it to include a national presence and raise all the boats there as well. So with that, Anthony, I'll hand it back and let David get into some more of the details.
Excellent. Thank you so much, Doug. Now we are going to hear from David Kendrick, CEO of MyHealthAccess. David, thanks for joining us today.
Sure. Thanks for having me. So, you know, confession quickly, I am a physician, so I'm really the cause of most of your pain, everybody on this call, and take that role seriously. So I have more slides than everybody else. But no, I'm with MyHealthAccess Network, which is a health information exchange in Oklahoma, and this is sort of the locations we serve across the state, similar to Doug's map. And we connect a lot of organizations besides just hospitals and clinics, ranging from long-term care and hospice and local pharmacies and so on, to try and make the whole picture, the picture of the whole patient pop out for the provider when they take care of them. Interestingly, this is the data, these are the home addresses of the people who received care in Oklahoma in the last 5 years. And what this map says to me is we really do need nationwide interoperability in order to deliver comprehensive care. But it goes a bit further even than comprehensive care. If we talk about disasters, for example, this is a picture from the New York Times about the diaspora from Katrina. That is the 1.4 million people who left New Orleans and where they wound up after the storm. And where they made their FEMA claims from. And what you can see is, and probably experienced wherever you are, was an influx of folks with the particular health issues that New Orleanians have. And I trained there at Tulane, so I'm well familiar with that. I worked that disaster and became really convinced of the necessity of having health records follow the patients, but also other opportunities that come about in disasters. And here in Oklahoma, of course, our primary disaster, at least, now that we also have earthquakes, but our primary disaster remains tornadoes. And our health information exchange, our sister health information exchange that we've now merged with, was used extensively during the large Norman tornado that you may have heard about several years ago. And so these are some of the lessons we took away from that. First of all, in the pre-disaster situation, you can prepare and you can organize the medical records for all individuals. You can have their identities resolved. And one really important step you can take is you can start to identify the most vulnerable patients at a community level. Who's on dialysis? Who needs oxygen? Who needs day-to-day, everyday touch from the healthcare system in order to survive? We got to find those folks, put them on a map, and make sure they are part of the evacuation plan. And then when the disaster itself is unfolding, we got to provide access to those medical records and the demographics while other systems are down or inaccessible. So we often see this happening in our community when an EHR is down, just the server's gone down, or you know, during the Nuance situation not too long ago, we were able to provide access to records as well. So we're a backup in that situation, but certainly during a disaster, we're also a great source of backup records for providing care. And then, of course, the ability to, as most HIEs are structured, to receive data in pretty close to real time from their sources, the real-time monitoring of resource utilization and potentially the additional needs that need to be met as possible. And then finally, post-disaster, ensuring that the medical records are available for those folks that have evacuated or been relocated. And then, of course, return records home when people come back home. And we've seen all of these occur here in Oklahoma, and now with the patient-centered data home, this becomes a much more national effort. But I also wanted to talk a little bit about other reasons to participate in health information exchange. And of course, you guys are probably all familiar with value-based payment models and are being asked to participate in ACOs and spin up population health management systems and write a lot more checks to your EHR vendors to have these new tools. But value-based payment models are something that health information exchange can play a role in as well. This Venn diagram shows a bunch of different programs that as providers we're all trying to support and meet. Some of you guys may even have a CPC Plus program in your communities. And of course, with MIPS now coming online, we've got a big burden of quality reporting and clinical practice improvement activities in addition to just proving interoperability and the meaningful use components. So here in Oklahoma, we had the privilege to participate in a program called the Comprehensive Primary Care Initiative that started in 2012, and MyHealth, the HIE, was at the middle of this, linking all of the payers and the providers to one another and moving the data. And this was a multi-payer model that brought $100 million in practice management or care management fees just to primary care practices in Northeast Oklahoma. So that's a pretty good per capita investment. And for the practices, it was about 90% of the covered lives were in the shared savings program. This shows the year 3 results, and I will tell you all 4 years of this program have saved money. This particular year saved 5.4% on the Medicare side, which produced $10.8 million in shared savings back to the practices, which amounted to nearly $200,000 per doctor participating in the system, in addition to the fee-for-service revenue they generated. And so this has made a lot of providers believers in this model of payment and service delivery. And of course, with health information exchange in the middle, we've been able to help drive some of those cost savings by providing alerting for admissions, discharges, and transfers, providing quality measures just in time. And the commercial payers in this program take their quality metrics actually from the health information exchange, as I'll show you in just a moment, rather than from the practices themselves. So now we're in CPC Plus, which is in Oklahoma, 181 practices across 5 insurers. And in Michigan, I know they're participating in this, as well as a number of other regions around the country. And so it's exciting to see when a practice or a health system begins to take risk, begins to sign contracts that are value-based payment contracts, the opportunities with health information exchange become much more clear and much more visible. It's not just about what information I know in my system. I need to know what everybody knows about the patients I'm responsible for. And so we sort of embrace this picture of how real patient data looks. As you see several different, a bunch of different EHRs or practices there. You see just four patients on this chart have data in a bunch of different places. And if, they probably represent people with diabetes or with high blood pressure or some chronic disease. And those are the folks that represent our primary targets, our most fruitful targets for intervention. But if their data is indeed scattered like this, you see across different insurers and across different information systems, it's difficult to imagine delivering comprehensive care cost effectively. And just to put some numbers to this, in all of MyHealth across Oklahoma, where we have about 3.5 million patients, so that's all the well and the sick, 43% of people have records in 2 or more EHRs. And we think we have about 45 to 50% of all the EHRs connected to us now. So you can imagine this number goes up pretty significantly. The average primary care provider is asked to coordinate care with 225 other doctors in 117 other organizations. But if we just give these patients one chronic disease, this number climbs quickly to 2/3. So in MyHealth, we've been asked by our community to get certified as a qualified clinical data registry, which means that we are able to be a reporting agent on behalf of practices and health systems to Medicare, both for individual and group reporting for MIPS and for the CPC Plus program as well. We can do quality, advancing care information, and improvement activities reporting. And under quality reporting, we provide reporting on practice or at any level that the organization wants to report. And we find already a number of practices able to report, a full year of measures even though we're not even done with the year, and maximize their score because of the ability to have data from multiple clinical sources on these patients that as a health information exchange provides. Then, of course, for the typical meaningful use requirements, I put these here mainly for documentation so you guys can reference later. A number of these elements are amenable to support from a health information exchange. In particular, what will become effective next year, the requirement for the hospital to access 50% of, document on 50% of folks that they admit or that they deliver care to in the hospital is going to be really important. That's the transition of care requirement. And then under clinical improvement, practice improvement activities, just participating with a health information exchange who is a QCDR gets each provider enough credit to cover their improvement activities. And the other reason that I'll mention that this is important is because it turns out that the performance benchmarks, as you may know, this will be the first year that quality measure reporting will be publicly available on all providers in the country or all groups. And also it's not like the PQRS where I just had to report. I actually have to be ranked in a percentile. And so this shows 3 different sets of baselines. You see the green line there, and the orange and the blue line. The orange line is if you report your quality measures from your EHR, you've got to, in order to hit the 90th percentile, the practice has to have fewer than 3% of their patients out of control on their diabetes. But if you report from a QCDR or a registry like MyHealth, you can have 17% of your patients out of control and still make the 90th percentile. Here's another example with cholesterol control. You can have as few as 6% of your system's patients in control and be at the 90th percentile in performance. And so we see a number of opportunities in this quality reporting to help report at a community level and ultimately help health systems and providers perform better. And frankly, this is a closer to true answer since we're measuring at the community level and not just within one of those EHRs. So there are a number of other initiatives that this patient-centered data home can support in addition to making those quality measures more accurate. In several states, the Prescription Drug Monitoring Program service is interfaced with the Health Information Exchange. I mentioned already the Qualified Clinical Data Registry service that we provide at MyHealth. We are connecting and supporting behavioral health programs, which, as you know, are not on the typical EHRs that you might reach through an Epic or a Commonwealth interface. And so by connecting those behavioral health clinics, that provides critically important additional sources of information on the patients. We also are tracking, as Doug was saying, tracking and addressing health-related social needs in the Accountable Health Communities programs, so that we're documenting who's got housing needs and food needs and transportation needs and so on, because these are often the cause of an inability of a patient or family to get healthier, to get better. And then finally, the 21st Century Cures Act, which you may have heard of, is also focused on generating new knowledge from this data. And by having this more global community level where a patient's whole record exists in our systems, provides a great opportunity to understand what's really going on in disease. And so just to close out where the patient-centered data home is moving now, what you see are the red, orange, and blue lines connecting the regional hubs that Chuck was talking about, and the green lines are coming into play to connect the hubs to one another, so that will provide those initial 3 in the middle, that triangle, to connect the hubs will connect almost 40 million patients to one another, and then bringing the Northeast region, Southeast, and Northwest regions on will cover pretty much the rest of the country. So we're excited to be announcing soon the linkage of those hubs. Now, the implications of the patient-centered data home beyond what we've talked about already, which are sort of public health needs, as Doug was discussing, the disaster response and planning, as I was discussing, and also quality measurement and improvement. Some of these other concrete things we talk about are the ability now for the first time to do nationwide ADT alerting. That is, unlike, say, eHealth Exchange or Care Everywhere or Commonwealth, where I've got to query out and get a response back, the nationwide ADT alerting through the patient-centered data home is a push to me whether I knew I needed it or not, and that's incredibly helpful for setting up the next set of transactions. Care gap analysis, quality measures I already mentioned can be more effective. National patient identity assurance, you may know we don't, of course, have much progress on getting a nationwide patient identifier, but in the patient-centered data home model, we are resolving identity in each other's communities so that we have a shared common identifier on the patient already without needing to make it a single nationwide identifier. And then, of course, patient consent is something that's difficult and variably handled in different systems. The possibility exists with a model like this that we could have centralized patient consent in one place where all of our patients could go to manage their consent. And finally, to start to allow our patient portals to have comprehensive data on each patient instead of just the data that each individual health system or clinic has to offer. So I'll stop there and open it to discussion and questions. Anthony?
Very good. Well, thank you so much, David. Appreciate that presentation. And now we have time for some audience Q&A. So I would encourage everyone, if you have a question for our panel, send it in. If you want it to go to someone specific, let us know, and we will get to that. We have a few minutes for some Q&A. Chuck, let me start with you. Speaking to hospital IT folks on the line, is part of sort of your agenda these days to get the word out more effectively about what HIEs are doing and what they can do, what they're bringing to the table? Is that part of what's going on?
Yeah, I think, and thanks, Anthony. Well, I think one of the really important things is that if you think about healthcare CIOs and the hundreds of thousands of things that they have on their plate, in the very beginning, HIEs were things that you had to connect to. And now that those connections, it's kind of like, putting plumbing in your house. Those connections are made. What do I do with it next? How do I add value to the organization? And what are some of the current challenges around, everything from quality reporting to case management to, just making sure that if we're a clinically integrated network, we're sharing the appropriate information back and forth. So how do we leverage that asset that now I have in order to prove that? And so the really interesting thing, particularly with the HIE organization, is a lot of the HIEs and their partners in their community have already solved some of those problems. So there's no reason for each community to, to find this solution on their own. And so we're trying to work together as a collaborative in order to share that. So what I think, I don't know if it's an end game or the end result is, because, I can speak CIO pretty well, I'm trying to help, one, educate myself about how people are leveraging this asset and use it effectively to have an impact upon the quality of care and help hopefully lower the total cost of care in the organizations and in the communities that we serve.
Doug, are you on a similar mission? I mean, when you go out there in your community, are you trying to explain to the different hospitals and health systems what exactly you offer? And do you find sometimes that they're surprised, they didn't expect you to be doing as much as you're doing?
I do think there's often surprise, particularly given the model and how we've grown it. I think what we've tried to be very tactical, because we haven't taken any federal or state funding and we are 100% privately sustained, it's focused us very intently on what are the problems that the hospitals and other providers across the community have that they're willing to pay to have us resolve. And I agree with Chuck. I think one thing that sometimes overlooked, though, is that basic blocking and tackling stuff that hasn't gone away. It's still there. The EMRs on the ambulatory side are being replaced, or their upgrades, or and all that interface, all that plumbing work still has to be done and maintained, while we look to, now that there's more value-based things, certainly the organizations that have taken on some level of upside and or downside risk. Before I cared about what happened inside my four walls. Tomorrow or today, I would think we can say, if I've got those contracts, I care even more what happens outside my four walls because they're going to affect me very specifically in my scores and in what I'm doing. So I think we're having those two conversations. Hey, don't forget, there's still a lot of this basic blocking and tackling stuff that has to happen, and you don't want to be focused on that. We can do that for you. And then also, as you're moving into these new spaces, there's nobody that has the record that we do to give you visibility into what's happening with the folks that you're responsible for when they're not in your four walls.
David, let me ask you, if you're a health system executive, a CIO, you know, you're looking at an HIE just like any other partner that you might work with. And, you know, not all HIEs are exactly the same. Not all have the same level of sustainability, same model, the same leadership. So if what would your advice be to a CIO at a health system about investigating and trying to figure out if their local HIE is a good partner?
Boy, that's a great question. I think that you know, the thing about health information exchanges is it's typically a nonprofit located in the community. And as such, their costs are probably not very high proportional to what's being spent on lots of other components of your tech stack in your enterprise. But the potential value for the data that you can get and the use cases that arise as opportunities for being solved are pretty dramatic. But the most important thing we have at MyHealth is sweat equity. We have the health systems who will take the time to participate in governance and to explore what the possibilities might be with the data. And that helps a health information exchange go from maybe fairly basic to pretty sophisticated over time, and even a short period of time. I mean, we are, our governance here in Oklahoma tries to be very responsive to our participants. So when we get approached by a health system or an oncology group who says we really need imaging exchange, we go pursue it. Because when they thought about doing that imaging exchange as a one-off between them, you know, CTs, MRIs, et cetera, they were looking at a lot of costs and a lot of PACS licenses, and we can do it for probably a third to a fourth of the cost and enable them to connect to a lot of other endpoints besides just themselves. So, you know, I did engineering before medicine, and so sometimes I think with my engineering brain and sometimes I think with my healthcare medical brain. And the engineer in me says, you know, put as many nodes as possible on the same network because that's going to be the most value per dollar spent. And the clinician in me says, make that work, do that, but make the workflow very seamless and keep me from having to check a bunch of boxes because, you know, I'm attesting that the mammogram is in my hands, or I'm attesting that the blood pressure is at a certain level, and instead have that data flow to me automatically, which becomes a real possibility with health information exchange.
Very good. Chuck, let me get that question in front of you as well. How can healthcare IT executives at health systems determine if they've got a sound HIE, their local HIE is solid?
Well, I mean, as the others have said, you know, being able to participate in the governance structure is really good. The other thing, too, is I think we need to remember that this thing called interoperability is really complicated. If it was easy, we'd already have it knocked out. And the other thing is, this you know, health information exchange can be both a noun and a verb, and it's more than one. That in interoperability is more than one thing. It's many things, and it depends upon, you know, kind of the use case. I mean, you've listened to and heard, you know, a lot of different use cases we're talking about. And that's one of the things that I think that the Patient-Centered Data Home does, is provide one really good opportunity to address some use cases. And so I think, you know, for a healthcare CIO is if you're looking at your HIE, you're looking at what you're spending, and you want to know, you know, the question was always for me when you know, I was one being courted about, you know, should you hook up to the exchange or not. I kept looking at, you know, what's the value proposition, what's in it for the organization, and how do I justify that expense? Well, part of that is are they good partners? And in that, I don't mean, you know, they're just not a data supplier or or a data transferer, which is really good Southern English for me. But they partner with you to help address the issues. You know, you heard both Doug and David talk about, you know, rolling your sleeves up and trying to figure out what's important for, you know, that individual organization. We have some very large health systems that are our members that we work with every day. It's really a learning experience for me because I get to view the organization a little bit differently from a business perspective and some of the strategies they're trying to come up with, particularly if you're trying to use technology to weave together these things that we call you know, the clinically integrated networks. Those are not easy to do, and they drive on data. So does all of the advanced payment models out there, like ACOs and those type of things. It requires a massive amount of data to understand where you're looking at for where your patients are getting care. You know, I know myself, I've got, you know, a handful of providers because I've got a couple of specialty health needs, and I can't get it all from my primary care doc. I have to go other places. And we use the technology to weave that information together so you know, all of my physicians know exactly what medications are on. They know my allergy. You know, one of the most bright spots in my my transitions back to Indianapolis when I went to one of my specialists and the lady handed me the clipboard to fill out all the paperwork, and she said, "Oh no, I don't need it. I already have that. We transferred it electronically." And I said, "Hot damn, it's finally happening." And so those are the shining lights. As we can do more and more of that to unload that burden, then we know that the technology that we're putting in place is actually working.
Very good. All right, Doug.
Anthony,
oh, go ahead.
This is David. I just forgot to mention one thing. I mean, the HIE website does list all the members of the Strategic HIE Collaborative, and those are the folks who have an opportunity to be on the Patient-Centered Data Home right now. So that might be a resource people want to look at. Just Google Strategic Health Information Exchange Collaborative.
Excellent. Excellent. All right. Doug, I'm going to give you the last word here. One of the big questions about HIEs in the past has been sustainability. Where are we as it comes to sustainability? Are they all set up differently? Are there some major models? And are there any that stand out as being ones that work pretty well?
Yeah, I don't think there's any one model per se. I think like in business in general, there are different ways to skin the cat. I would say, and I don't know that it's you know, that it's a scary comment, but I don't think HIEs have a right to exist just because they're an HIE any more than any other business has a right to exist. I think that to the extent that health information exchanges across the country are getting well in tune with their communities and solving real problems that are adding value, how that gets paid for may vary. But I think those that are working and those that are part of HIE are all finding in their communities within their local context and how things are kind of organized, governance, all that sort of thing there. What's true, I think, about all of us is we're solving some real problems. We're adding tangible value that people can feel and are willing to pay for. And I think as long as we continue to have that focus and really understand that even more broadly, to maybe get to your previous question just for a second as well and add 2 cents, most health systems, if not all, have something in their mission that talks about improving the health of the community and the residents that they serve. And we do these community health needs assessments where we talk about the needs in the community. A lot of the things show up on there year after year, but most of them are things that an organization can't do on its own. So the quality of the HIE, the quality of its value, the problems that it's solving is in part going to be based on the investment of the provider community, the stakeholders around that HIE to really bring it to a place where it can solve some of those things on a community-wide basis that have been sitting out there in problems for a long time. So as long as we keep finding those problems and adding value, then I think there'll always be ways that that stuff gets funded.
Excellent, excellent. Well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a survey. If you could take a moment to answer that, we'd appreciate it. For those of you with continuing education interest in today's event, attending our events gets you 1 CEU towards the CHIME CHCIO certification program, so let CHIME know you were here, and if you've asked us to do so, we will. If you need a certificate of attendance for another CEU program, you can see the final slide in this deck. You'll receive an email when our archive recording has been posted to our YouTube channel. And if you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox on our team. And if you want to check out our upcoming schedule, which is quite robust, you can go to our website. And so with that, I want to thank our speakers, Chuck Christian, Doug Dietzman, and David Kendrick. And I want to thank you, our attendees. Everybody have a wonderful day. Thank you.
Great, thank you.